One of the things from pre-hospital is that we're trying to keep it as simple as possible so that we have a very quick algorithm for an airway or an airway manoeuvre, so that we really want to have 4 steps in it. And one of the things that we find from a critical care point of view is that we are either intubating the patients with an endotracheal tube, or we're using an LMA fast track as our rescue device before then going to cutting the neck. There is a lot of discussion about what other devices would fit in the gap between there, and I think you need to look at our patients, which are undifferentiated, non-fasted, different body habituses, drug and alcohol affected in many cases, and which is the best device for that particular patient. And again, we can't carry everything. We're really limited with space and weight with what we have on the helicopter and on the planes that we fly. So we need to be very careful that whatever piece of equipment we choose gives us flexibility through multiple scenarios. And that's why at the moment we are using LMA fast track, but like anything, we keep our head by looking at the literature and seeing what would fit and what we can go to. And it's one of the things that are being looked at in South Australia at the moment is the change to the Supreme, and whether or not that would replace a unique, which we also carry in our airway kits at the moment. That's something that we look at with the available evidence and with our case mix. So there is definitely a role. It fits well within our algorithm, but with that role becomes a training debt, and also comes the ability to be flexible with all the situations that we're faced with.